Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan. Now, here is your host, Joe Steckler.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County. Our focus is designed to provide you with information on how to develop your own aging and care plans. Our topic today is emergency room care. And with me in the studio here is Dr. Janel Keener, emergency room physician with Wuesthoff Health Center, and Donald Kreuger, registered nurse, also with the Wuesthoff Medical Center. Welcome, Dr. Keener. Welcome, Nurse Kreuger.
Thanks
you.
For inviting us.
Yeah. We're going to do this special half-hour show on emergency room care. There's a twofold purpose in it. We want our viewing audience to know what happens in an emergency room, but we're also going to use parts of what you all will talk about because you were the physician and you were the nurse that took care of me when I had a stroke roughly 3 months ago.
Mm-hmm.
And it's important for our viewing audience to not only understand what happens in an emergency room, but the importance of the viewing audience understanding the need for quick response in emergency situations.
Yes, sir.
And we'll draw from this to put together a series of shows on stroke. What, Dr. Keener, is an emergency room? What do you do primarily in an emergency room?
So emergency room, I'm Dr. Keener. This is Dawn, our nurse. We're part of the emergency medicine team that staffs an emergency department. We're here for any unattended visits that a person may need. We're open 24 hours a day, 7 days a week, and we're here to treat a broad spectrum of illnesses and injuries, whether you have the common cold or a small cut to your finger or something more severe like a heart attack or stroke. And so we're here to treat all those broad illnesses.
And you raise an important point. I don't think a lot of people realize that there are really, when we say we go to emergency room, and people say, well, why would I go to emergency room for a cold? Well, if they don't have a doctor, they go to an emergency room for a cold. But that's an element of care that you deal with, and you can quickly get those people out the door. But you mentioned two key words, stroke and heart attack. You don't get them out the door so quickly.
No. Usually people, when they come in with more serious illnesses, stuff that are potentially life-threatening or have the complication of worsening disability down the road, usually these people end up getting admitted for further medical management. Our job is, once they come to the emergency room, is kind of recognize the key symptoms and what's going on, help stabilize them, and then get them to a place where they can go for further care that's appropriate for them. And usually that's admission to the hospital.
Okay. What is there in your background? What type of training qualifies you? Say if you were an emergency room physician, did you have a specialty?
Well, emergency medicine is my specialty.
Oh, okay.
Just a little bit of background. So years ago, emergency rooms and departments were staffed by all types of different doctors. One night you could have a pediatrician on, next night you could have an ENT doctor on or a surgeon. And so they started realizing that, there's all types of people that come in that need emergent care or need to be stabilized. And sometimes the people working in the emergency room weren't necessarily equipped to deal with that type of thing because they were specialized and they weren't used to seeing certain things like that. Okay. So then they found that there was a need to establish emergency medicine. So, you go to medical school and they came up with emergency medicine residency programs. It's anywhere from 3 to 4 years training, and all you do is emergency medicine. And the whole goal of that, is to be able to take action and to recognize certain people that come through the door, which people are sick and who's not sick, And along with that recognition, we're also trained, to treat these people and to stabilize them and then to further disbone. Sometimes people may go home or sometimes they may be admitted to the hospital. And so that's where kind of the specialty comes from. And we're we're kind of a jack of all trades. You know, we do pediatrics, we do cardiac stuff, you know, we do stuff with strokes. Sometimes we do broken bones, we do lacerations, because we can't control what comes through the doors. Because our goal is to get to people to the appropriate care where they need to be.
What I'm hearing though is that you have been trained in a broad degree of specialties such that you're, with fairness, can almost address anything you see come through the door to get it stabilized.
Correct.
Okay.
Yeah.
And as you as an emergency room nurse, Don,
Well, I've been doing this for 24 years now, and an organization named Emergency Nurse Association has been taking the lead in educating emergency department nurses over the last 20 years. And they developed some courses, trauma nursing core course and an emergency nurse pediatric course that are instrumental in making sure that the nurses working in the emergency department have those skills, those broad skills, like Dr. Keener was talking about, to be able to identify those sick people from those that are not so sick and may be able to need to wait. And that really is the skill that we try to teach all of the staff that are in the emergency department, who needs to be treated first and prioritizing. And as we talked earlier, the airway, breathing, and circulation, the ABCs of emergency medicine.
Yep. And you showed me on my chart where my ABCs were intact.
Yes. Initially.
My airway was open, I was breathing, and
You were talking, your heart was beating, you were breathing, and
did I make sense when I was talking?
initially, yeah. When you came in, yeah, you were with it, you were oriented, you were talking, answering appropriately. You did have a slight, facial droop, but then, as the time went on, you slowly or quickly began to decompensate.
Why can't I remember any of that?
Well, for one thing is during your course, you did have a seizure.
Okay.
Okay, so a lot of times when people have a seizure afterwards, they have what we call this post-ictal phase, where it's like you're in this deep, hazy sleep. So a lot of times people don't remember.
I don't remember anything. I remember that was the last.
That's good.
Yes.
I wouldn't want to. That's good.
You said it's good I don't remember.
Your body's like, yeah.
Well, I had just finished my last back therapy session, and I remember walking the therapist to the door. And the next thing I woke up was here in the emergency room with that tube stuck down my throat. And I asked you, did you put that tube down me?
I did.
You did?
Yes.
You did it on purpose?
On purpose, because it was medically necessary at the time.
Okay, why? Generally, when people come in with a stroke or a heart attack, do you intubate them almost all the time?
No. A lot of there's main reasons for intubating somebody. And for those that don't know, intubating is when we place a tube down your airway so we can breathe for you and make sure you're getting adequate oxygenation, make sure you're breathing okay, and making sure you're getting adequate oxygenation. And sometimes not everyone needs to be intubated, especially if they come in with a heart attack or stroke. Like Don was saying, as long as your ABCs, your airway, breathing, if you're talking to us, we know those are intact. We're not just going to intubate someone just because.
But what did you see in my case and put it down me?
What happened with your case is, you came in talking, everything was fine, but then you quickly deteriorated. You went from answering appropriately just because you said you had went down for a nap, woke up, noticed a little bit of a facial droop. You could tell me what year it was. You could tell me where you were at and what was going on. Then within a short period of time, you had a seizure. And then afterwards, you you went from a small facial droop to where you weren't moving the entire left side of your body. And then you weren't responding. Because before I could be like, hey, Joe, and you would answer appropriately. Now I could touch you or try to stimulate you and you weren't responding. And to me, as an emergency physician, that's a sign that, okay, something has drastically changed. And it gets to the point now where what we call is you can't protect your airway. So we go ahead and intubate you, because now your body's not conscious enough to help to breathe on its own and to prevent further things like aspiration for you to choke on your secretions or other thing like that. So we go ahead and do it preemptively. because you are in such critical condition to help you breathe and to help supply like necessary oxygen to your vital organs, your heart and your brain.
Okay. In my case, my wife recognized that I wasn't responding. She called 911. They did the right things. They got me here. You described what you saw. What other things do you as a doctor and nurse see in an emergency room situation with heart attack and stroke that cause you to take actions that only you can do here in the hospital?
Well, that's when you said my wife took the most appropriate thing and called 911. That really is what probably saved your life. Many of our patients that come in decide they don't want to call 911. They don't want to have the ambulance show up in front of the house. They're being embarrassed. They don't want to pay for the bill. They have all kinds of excuses not to call 911. And at that point, they put themselves at risk. So your wife calling 911 brought the professionals out who are able to assess what's going on and actually able to determine which facility would be best for them. People get the wrong idea that all emergency departments and all hospitals in an area have all the same resources, and they don't. So your wife did the most important thing for you, and that was to call 911, get the professionals out of the house, determine what initially was going on, and then make that determination which hospital to go to. They gave us a call ahead, so we were prepared for you. So we had a room and we had all the resources, and we were starting to marshal all of our resources that we could to save your life and make your life a better one afterwards.
I had a dissecting aorta in 2004, and the man, Emil Miller, was the president of Heritage Hospital at the time. And he said, I was very fortunate that I had my dissection on a Thursday and not a Saturday, because I had the forces here that could cope with it.
Yes.
And I will forget that. Wuesthoff has a program here that sort of sets your emergency room apart from other emergency rooms. And I did a little research. I cheated on you. I went to the internet and I looked it up, and it's called Emergency Room Extra. What does that mean? How does that make this emergency room different from an average?
Well, some of the programs that we're starting to put in place is to try to expedite some of the diagnostics that we were trying to get on a stroke. So the first thing that we needed to do when you arrived in the emergency department was get a CT scan of your head. That is the most important diagnostic tool that we can have. And we're streamlining the registration process to the point where we're now discussing the possibility of that patient not leaving the EMS stretcher and going right to the CAT scan. So it would be from the back of the EMS vehicle right in through a real quick say hello, and then off to the CT scanner so we can get that diagnostic. So the extra things that our administration and our people that are thinking about these kind of things are doing is trying to expedite the diagnostic situations and then expedite the interventions for those.
Yeah, a good example of something that's already implemented and very successful is the way we deal with heart attacks and what we call cardiac alert. So a lot of times when 911 is called, they'll go out to the house, they'll assess the patient, and they'll do an EKG, which is like a tracing of the heart. And sometimes you can determine if someone's having what we call a heart attack by the EKG. So what EMS will do, not like the paramedics, in the field, like when they're out by, say, for example, your house, they'll fax us or transmit us the EKG. So then we can see the EKG before the patient has even probably left their house or is still in the driveway. And we look at the EKG, and if it has concerning things on the EKG, what we call like a STEMI, then we go ahead and call our cardiology team, because we have a cath lab, so we have interventional cardiology, so they can be bedside when you're there, and we have the whole team there. So once you arrive to the emergency room, we can expedite your care. And, you'll hear this like door to balloon time kind of thing. And that's huge, because whenever you're dealing with a stroke or a heart attack, it's a race against time. Because with a heart attack or stroke, part of your brain or heart, part of that is being deprived oxygen. And when that organ is deprived oxygen, it starts to die. So we're in a race to stop that and to help save what's left of the organ and help like reperfuse, like reinstate that blood flow and oxygen to that organ. So it really is a race against time. And so with the EMS and the way we do our cardiac alert, it's great. So a patient can come in that, had chest pain, and within, sometimes I've seen them like less than 15 minutes. Yeah. As soon as you hit the door, then you're on what we call the cath lab table, with a cardiologist, getting the appropriate interventions you need to help restore that blood flow. It's impressive. And it's great because we're a cardiac care center. We can provide that.
Okay. Many people don't understand that there are different types of strokes. Can you explain to our viewing audience the type of stroke I had, the difference between what I had and what the other stroke could have been, and why a CT scan was so important in my case?
Yeah. So basically, there's two types of strokes. You have ischemic stroke and a hemorrhagic stroke. So ischemic stroke is when you have a blood vessel that gets blocked or occluded and stops blood flow. And, the blood carries the oxygen. And so that area of the brain is not receiving blood or oxygen. And then it gets injured and can lead to that part of the brain dying, that actual tissue. So that's an ischemic stroke. The next is a hemorrhagic stroke, which is what you had. So you have blood vessel in your brain, and for some reason the vessel wall weakens or something happens to cause that vessel to leak or to rupture, and you end up having bleeding in your brain. So this is an issue too, because then your brain can't utilize the blood or oxygen anymore.
Okay.
So you had a brain bleed. And the thing is, because it's compromising a part of your brain, it's going to present a lot of times as a stroke. A stroke is when you have some type of what we call neurological deficit, whether it's a facial droop or you have weakness or changes in your gait, like when you're walking, or like vision changes. Something happens to your neurological system.
But in my case, the fact that I'd had a dissecting aorta and having an aneurysm on my right iliac, and then not wanting to cause or to lessen the chance of a stroke, they had me on blood thinners.
Right.
So with the type of stroke I had, it became more important for you to know the status of my head and the bleeding. Because what would have happened, generally speaking, you can put a tube in to drain the blood, right?
In surgery, that would be the
neurosurgeon. And it depends. They have certain criteria that they decide, like when they need to take something to surgery or when they don't.
Was there any thought of me having to go to surgery?
Because at the time we had called the neurosurgeon and he was bedside evaluating you. And at the time, the bleed was not large enough to take to surgery, because sometimes bleeds are small enough where they can reabsorb, the brain will reabsorb it and you can go on and be okay. So at that point, when you come into the emergency room, the next important step is we have a neurosurgeon on staff here who's very good, excellent, Dr. Matuk. And so he's my gosh, they have years and years of training. So it's his specialty and his call to say, look, this is a small bleed. The risk of going to surgery is greater than if we just watch it. And a lot of times they repeat the CAT scans or do different tests that we can't do in the emergency room. But the biggest thing too with yours is that you were on this blood thinner called Coumadin.
Right.
And with the brain, with your brain actively bleeding, what we had to do is then what we call reverse the anticoagulation. So we had to give you, because your blood's super thin because you're taking the Coumadin. So now we have to stop that super thin blood to help prevent worsening of the head bleed. And we had
did you give me something to coagulate my blood?
Yeah, it's called, we gave you some fresh frozen plasma. It helps with the clotting factors of your blood. It helps to make it a little less thin. We also help control your blood pressure. Gave you a lot of blood pressure medicine.
To lower it.
To lower it, yeah.
Oh, was my blood pressure high?
Yeah.
Was when you first came
When you first came in, it was pretty high.
We've got my chart here, folks, so we're talking exactly.
You're looking, yeah. Not that good to remember your exact blood pressure.
She does not have a photographic memory, no.
But 120 over 80 is like basically normal. I believe, I think when you came in, yours is like 180, 178 over 110. So that's elevated. And that's causing increased pressure in your brain and can worsen the bleeding. So our goal is, 1, to help reverse that anticoagulation, 2, get your blood pressure controlled, make sure you're breathing, and then we get the necessary specialties on board, like neurosurgery.
So when a person comes in the emergency room, they might come in with a litany of medicines they're taking, and they might have all kinds of problems.
Yes.
But as an emergency room doctor and nurse, your job is to address the reason they're laying on that table.
Correct.
That's the first consideration.
Correct.
What happens after? I know a little bit in my case what the doctors have done, but generally speaking, after a person leaves the emergency room, what happens?
I don't know.
We
I'm
don't
just kidding.
know. And that's been one of the questions that we've asked each other. We don't do a lot of follow-up. A few of the patients we get a chance, like you, Joe, we were able to see you and see that the work that we did brought some fruition, and that you're leading a great normal life again and making some major changes. And
My life is not normal.
well, no, but you're making an impact again still,
Yes,
and that's what we really we strive for in the emergency department. We're not always this fortunate to see the outcome of our efforts.
I think it's extremely important that that people that need medical assistance have good medical assistance available.
Mm-hmm.
And that's one of the reasons we started this organization called Helping Seniors of Brevard County. Our objective is to inform and educate the general public about the many wonderful resources we have in Brevard County to help people, and even more important, help them understand that they can access it.
Mm-hmm.
We've got a little time. I have a case right now. I was called yesterday by a man. His wife is 48 years old. She had a stroke. No insurance. He lost his job. He has a 401k that they reclassified as an IRA. But Medicaid stopped for his wife. She's not receiving any kind of care for her stroke because she can't pay for it. Well, there's got to be a way to solve that problem. The woman needs to learn how to walk.
Mm-hmm.
We have resources in Brevard County that can help them. I think I can help put them in contact with somebody that will help this woman. But that's just an example of what happens and what doesn't happen. In my case, when I left Wuesthoff, I went to Sea Pines.
Mm-hmm.
I left Sea Pines with 18 medications. The first thing I did was call Gene Calibi, my cardiologist. And he says, no, no, yes, no, no. And then I went to my primary care doctor, and he said, no, no. I went to a neurologist, and he said, no on this one. So I end up with 7 medications, basically, I think, morning and night, that really make a difference. And one of them is a seizure medication. But I'm fortunate. I had access to a good emergency room crew. I've got all these things here, but you've talked about heart attack, you talked about stroke. As an emergency room nurse, what have I not asked you and Dr. Keener that you would want our audience to know about?
I would want your audience to really pay attention to your body. If your body is telling you that there's something wrong, you need to address it. You need to call 911. Don't get in the car and drive around. The professionals are there to do that. Sit down, relax, call 911. If you've got an aspirin and you're not allergic to it, take an aspirin if you can. But call 911 and let the professionals take care of you. Stay off the road. Go to the right facility that the EMS people will take you to.
Dr. Keener?
I agree with that. And in addition, too, I think not only for someone being aware of that, but also to the family members and neighbors and to whoever's in your support system. It's really important, that be aware of your surroundings and situation. If your mom or neighbor is not acting right or has a little bit slurred speech, then is the time to act. Or if you notice a little bit of facial droop, a lot of times what I see is very frustrating for me as a healthcare provider is that, someone will be like, oh, well, they had a little bit of slurred speech. I thought it would get better. And then what starts off as a small stroke, then ends up into a few days later, they wait. You're like, oh, I think it's going to get better. I didn't want to bother you. We didn't want to come in. Evolves into a full-blown stroke. And now it's like you have this huge disability. These people end up like not able to walk, not able to talk. They end up bedridden. Stroke is the third leading cause of death in the United States right now, but it's also the number one factor for disability, for people's quality of life.
Right.
So I think the biggest thing too is like, if when in doubt, come, the brain and the heart, you need those to survive. They're not very
That's a hard
forgiving
call.
organs.
I'm 80 years old, and I've had so many things happen to me, and sometimes some of these illnesses, some of these effects, it's like a cause and effect relationship of my body. It's like I can't put one foot in front of the other.
Right.
Mm-hmm.
And I don't know whether to go to the emergency room or not. It's a hard call.
It is a hard call.
It's really hard.
People are afraid of the emergency department. They're afraid of all the chaos that goes on there sometimes.
I'm not afraid of it. No, I'm not afraid to go to the emergency room. I'm not afraid to call 911. But
Maybe
I think a lot of people, I don't want to take or use a resource that I really shouldn't be using it. And that's a hard call. But I would say err on the side of caution.
Please do.
I mean,
Please
that's
do.
our job. That's why we're here. We're a team, and we deal with this on a daily basis. And we both had extensive training, and, we're trained to recognize, what's life-threatening, what's not. And, that's why you come to us, because we're a professional team that works together, and, we're here to be a patient advocate, provide the appropriate care, and to recognize, like, what's life-threatening, what's not, So you can come in. Anything with, anytime you have any weakness, slurred speech, any type of facial droop, any time you have an acute change, like something different change, like with walking, or anytime you have any type of chest pain, chest tightness, any type of those things, I definitely call 911.
And time is important.
I know.
Time is important. No, we have to intervene early to be able to save things. So time is important.
Thank you both. And I want to
Thanks.
thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call us at 321-473-7770. For more information on senior care and resources, visit our website at helpingseniors.brevard.com. And be sure to watch Focus on Seniors or listen to Focus on Seniors radio show on radio station WMEL AM 1300 every Thursday morning. And you can also see our column Focus on Seniors in the health section of every Thursday issue of Florida Today. I'm Joe Steckler, and I thank you for joining us today for Focus on Seniors. Thank you both.
Thank you.